Good morning, everyone. During the next 25 minutes or so, we're going to be talking about laboratory testing, particularly about advances in thyroglobulin and thyroglobulin antibody testing. The focus would be assessing the analytical performance of the current available assays for this test and talking and recognizing the limitations of thyroglobulin and thyroglobulin antibody test. If you cannot hear me at some point, please let me know. Let's start with a case. This case is of a 53-year-old woman that had thyroid carcinoma after thyroidectomy and ablation therapy about 2 years prior. The patient is on levothyroxine and is euthyroid. And at the time of this presentation, the patient was tired and anxious. As you can see here, I am showing you different laboratory testing. In the first two lines is the laboratory testing that we were doing at the time in our laboratory for thyroglobulin antibody using the assay, for thyroglobulin using the Siemens assay. And as you can see, there's detectable elevated concentrations of thyroglobulin antibody, which have decreased over time after treatment. However, the thyroglobulin has remained undetectable at the LOD, or limit of detection of 0.2 for the Siemens assay. At the time of this presentation, the laboratory was switching assays, as many of you are aware. And as part of this switch, there was a parallel testing or rebaselining that was taking place between the old assays and the new thyroglobulin antibody assays and thyroglobulin assays, which are made by a different manufacturer called Beckman. And in this occasion, the patient had a concentration of antibodies that was within the reference interval for thyroglobulin antibody, 2.4 international units per ml, and also undetectable thyroglobulin by this immunoassay. So naturally, this is going to raise many questions, right? Specifically about the discrepancy in the thyroglobulin antibody concentrations, one that is flagging as abnormal, one that is flagging within the reference interval, and what the implications are for the management of this patient. Okay. Just to rebaseline with this group, the gold standard for postoperative follow-up of patients with thyroid cancer is to measure thyroglobulin and also to do ultrasound. With the availability in the last decade or so, 2 decades or so, of highly sensitivity thyroglobulin assays, we have a way of measuring thyroglobulin with high analytical sensitivity, and we have been able to improve thyroglobulin measurement, particularly at the lower detection range where there's clinical decisions take place. All right. I'm going to ask this question for the audience. We don't have an automated response system, but what percentage of patients with DTC have a positive thyroglobulin antibody test at the time of diagnosis? A, B, C, or D? Well, the answer is up to 25%, depending on the assay and the reference. And the general population would be up to 10%. So a large percentage of patients with thyroid cancer are going to present with these antibodies. So this is important to recognize and understand how to manage, although there's many gaps in our understanding of how to manage this. But I'll get into this in a second. Well, I told you that there's been the development of new high sensitivity assays or newer high sensitivity assays that are termed by generation, first generation and second generation, very similarly to what we do with TSH, is based on our ability to measure low concentrations of thyroglobulin with high accuracy and precision. And there's different terms that are used, sometimes correctly, incorrectly, interchangeably, but we have all heard the term of functional sensitivity, which is the lowest concentration that can be measured with a coefficient of variation under 20%. And although this is vastly used across the literature, the better and preferred terms are limit of detection and limit of quantitation. The limit of detection is the lowest quantity or amount of thyroglobulin in this case that we can measure and is statistically different from a blank. And the limit of quantitation is the lowest concentration of thyroglobulin that we can measure within a certain goal for error, which includes bias and imprecision. And this is an introduction to the next slide where we're going to see where the different assays stand. Accordingly, we've had first generation assays, which was most assays up to fairly recently, and there's still some assays that are commercially available that will be in this category. So this would include radioimmunoassays and some immunometric assays, such as the one that we used until about 2 years ago in our institution. The Siemens assay would still be under this category according to the functional sensitivity of that assay. And as the sensitivity improves, and we have assays that reach down to detection limit of 0.1 nanograms per mil, these are second generation or high sensitivity assays. And then maybe in the future there's assays with lower detection limits, but the field is really not there. We are here with the second generation assays. So what are the characteristics of the commonly used immunometric assays? You can see here a table that is listing manufacturers, the thyroglobulin assay, the principle, and as I mentioned before, the different terms used to define the analytical sensitivity of the assay, whether it's the limit of blank detection, quantitation, analytical sensitivity, functional sensitivity, and so on. Of these assays that are listed here, not all of them are available in the US, cleared by the FDA. So those that have the asterisk are the ones that, to my knowledge, are clear in the United States. The assay that we used to use, as I mentioned before, was known as a conventional assay or a first-generation assay, which was the Siemens Imulite assay, which had a functional sensitivity of 0.9, even though we reported down to 0.2. The real functional sensitivity where we saw CVs of less than 20% was not reached up to 0.9. And our current assay is the Beckman thyroglobulin immunoassay, which has an analytical sensitivity of 0.1 and is regarded as a high sensitivity assay. I want to mention that there's other assays available, and some assays have been fairly recently available in the US after FDA clearance. So with that being said, this change in our institution brought us to the use of a high sensitivity assay. And I want to mention that most large commercial laboratory assays and academic medical centers are using the Beckman Coulter assay. So when we think about thyroglobulin measurement or any measurement in the laboratory, we need to consider interferences. And in terms of interferences, we're going to consider 3 interferences that are commonly consulted by the laboratory, including thyroglobulin antibody interference, heterophilic antibody, and biotin interference. There are other aspects of laboratory testing that confound the interpretation of testing. For example, the assay variability that exists across assays. We're going to focus on this, however. Okay. So the thyroglobulin antibody interference, it's well known to have the potential to reduce thyroglobulin concentrations, causing a false decrease result that would confound or affect the interpretation of thyroglobulin in a patient that may be monitored postoperatively with thyroid cancer. Over the years, the line of thought is that any detectable amount of thyroglobulin antibody is considered positive and has the potential to interfere. However, there's a couple caveats and discussion points about these statements. So first, these assays, these thyroglobulin antibody assays, were really designed and cleared by the FDA primarily to evaluate autoimmune thyroid disease. So when we think about a reference interval for this assay, it's based in this specific clinical context and not based on a cutoff to predict an interference by thyroglobulin. So the reference interval that we used to use of 14.4 or the reference interval that we would see of 4, for example, it's based on this indication. Well, commonly we get asked, is there an interference cutoff? Is there a cutoff, a concentration at which we can predict interference? And the short answer is not really, because there's really no correlation between the level of antibody present and the degree of interference seen, and there's many reports of even low concentrations of thyroglobulin antibody interfering with thyroglobulin. So there's really no consensus, and this may vary by patient, this may vary by the heterogeneity of the thyroglobulin antibody in that patient, and by what the assay is capturing in a patient. So I don't have good news about that aspect. This study that I'm showing here really highlights another important consideration with thyroglobulin antibody assays, which is the variability across assays and how patients would be classified as thyroglobulin antibody negative or positive, and how dependent this is on the assay that is used. So in this study of 495 patients, of which contributed 589 samples, about half of each were thyroglobulin antibody negative or thyroglobulin antibody positive by any of the 4 methods studied, which are listed here, which we reviewed a few tables ago. And as you can see, the number of thyroglobulin antibody positive varied significantly between assays. So for one assay, positivity was observed in 60% of the patients, and for another assay, it was observed in about 30% of the cases. In 40% of the cases, there was no assay that was positive, and all assays were positive only in 23% of the cases. So the different assays did not consistently identify the same patients regarding the variability and the heterogeneity of thyroglobulin antibody and what the assays are capturing, further complicating our ability to interpret thyroglobulin antibody positivity. So laboratories most commonly pick an assay depending on different criteria, including the platforms that they have available, and they stick with it. And at the time, there's no recommendations to use more than one thyroglobulin antibody assay, although we recognize the limitations of this approach. So how do we overcome the interference by thyroglobulin antibody? I want to say that the last consensus or position statement that was put on this topic was about 10 years ago, and very recently there was a new position expert consensus statement, which I'm going to discuss, which it's really challenging our thought on this topic. And as a coincidence, perhaps, Dr. Toro is an author and will follow my talk. This is a coincidence. Not a coincidence, but I was not aware until this morning. But a lot of what I'm going to be talking about in the next few slides, we have an expert in the audience that generated this consensus expert document. So ask him questions, not me. No, just kidding. So until over a decade ago, one of the consensus statements to handle this interference was to use a thyroglobulin radioimmunoassay antibody that was available in mostly one laboratory that generated a lot of the data on these studies, so it was not widely available. And it's a radioimmunoassay, so it's going to have suboptimal reproducibility and also analytical performance, particularly at the sensitivity. So this is somewhat outdated, and this is not common practice any longer. Since 2013 or so, there's been thyroglobulin antibody methods by tandem mass spectrometry. These are proteomic assays consisting of tryptic digestion and the detection of a specific peptide for thyroglobulin. These are highly involved assays in terms of the technical analytical requirements and the equipment that is required. So these are mostly available in reference laboratories at a higher cost. And even though they don't suffer of interferences such as biotin interference or antibody interferences, because you're measuring the peptide directly by mass spec and not using an immunoassay with an antibody that needs to detect it, there's some limitations to it as well. So mass spec is great, but in terms of the sensitivity of this assay has not been able to be challenged much more down than 0.5 micrograms per liter. And the evidence for the use of thyroglobulin antibody by tandem mass spec is evolving. It overcomes the limitations of thyroglobulin antibody interference, but there's really questions about the benefit demonstrated when you challenge patients that have thyroglobulin antibody present and the benefit of adding a test by tandem mass spec. And there's been recent knowledge emerging that even patients that have a positive antibody but are undetectable thyroglobulin measurement by one high sensitivity assay have a very low risk of structural disease, really putting into question our practices of more systemically measuring thyroglobulin by tandem mass spec in patients that may have positive antibodies. Okay. So I told you we switch assays, right, to the Beckman assays. At the end of 2022, we started this journey with parallel testing. And at the time, these consensus guidelines or experts' consensus opinion had not come out. So we came up with this protocol at the time. So this is our current practice. A thyroglobulin is ordered, and the algorithm starts with measuring thyroglobulin antibody using the Beckman assay. If it's negative, under a cutoff of 4, the thyroglobulin is measured by immunoassay. The cutoff of 4 is also used by another medical center using the same assay, and it was derived because it maintained the positivity of thyroglobulin antibody at that institution, and it also maintained the same positivity of about 9% in our population. So not very rocket science, but more arbitrary criteria to define that cutoff. If positive, thyroglobulin is measured by tandem mass spec. Even though this has been our practice for the last year and a half, we've collected data by immunoassay for all these measurements, which falls behind the scenes, and we plan to reevaluate, to reassess this practice, which was really a starting point with our high sensitivity assay at our institution. Well, I just said that a couple months after we implemented our assays, middle of 2023, there was this document put out there, which is an expert consensus consisting of a group of international endocrinologists, as a laboratory scientist or clinical chemist, and so on. And the proposed algorithm consists of continue monitoring patients that are thyroglobulin antibody negative using high sensitivity thyroglobulin immunoassays, which should really be current standard at this point, and any assay that is conventional assay should be probably phased out at this point. Where it gets sticky and tricky is with the thyroglobulin antibody positive patients, right? So these experts said if thyroglobulin is undetectable, they are discouraging routine additional testing on patients, even though they have antibody positivity. One recommendation is to consider using thyroglobulin antibody as a surrogate tumor marker and focusing on trends, whether it's decreasing or is stable, and to only consider alternative testing, such as thyroglobulin by mass spec, in cases when there's a discrepancy between the biochemical findings and the clinical finding in the patient. So this is really challenging the thought that we've had that we should be very concerned about positivity of thyroglobulin antibodies, and that regardless of the immunoassay result of thyroglobulin, we should consider interference. So it's saying that this, or is suggesting that thyroglobulin, high sensitivity thyroglobulin, is reliable even in the presence of antibodies. Okay. Question number 2, as we switch gears to talk about more broadly heterophilic antibodies. What percentage of patients show interference with heterophilic antibodies? In contrast to the very high percentage that we see with thyroglobulin antibodies, a very low portion of patients with thyroglobulin testing had an interference by a heterophilic antibody, only 1%. So something to keep in mind when you're suspecting an interference. So the term heterophilic antibodies, we tend to use it to group both heterophilic antibodies, which are non-specific antibodies, which are very interact very poorly with immunoassays, mostly in the FC region, and anti-animal antibodies, which are more specific, may be developed after treatment with therapeutic drugs or exposure to animals, for example. So we use these terms, heterophilic antibodies, to encompass these. There's also autoantibodies and therapeutic antibodies that may interfere with immunoassays. The most common mode of interference is a positive interference. A negative interference is rare, but in this case, there's a heterophilic antibody that may link the capture antibody and the detection antibody, even in the absence of antigen. In this case, it would be thyroglobulin causing a positive result. So even though the effect can be positive or negative, these would be more commonly regarded as a false positive, as the cause of a false positive. And it's traditionally associated with a sandwich assay. Also, we've also seen reported interferences in competitive assays. So how do we overcome these limitations? So we rely on providers and clinicians calling the laboratory and saying something seems off, something is not matching. And once we get that phone call or that email, we can do different treatments to assess if there's an interference. We can treat with blocking reagents. We can do serial dilutions. Preferably, we can also use an alternative immunoassay or an alternative method that is not prone to interferences, or PEG precipitation. And given the low prevalence of these interference, it's not routinely recommended to evaluate for heterophilic antibodies, only to assess these in the presence of discordant clinical presentation and biochemical findings. So why are we still talking about biotin? I know this group of endocrinologists know a lot about biotin interference and is hyper aware of this interference. So The interference that we see with biotin is going to be assay and analyte dependent, which every manufacturer putting in their information, what is the threshold at which interference is observed, if this is a biotin-based assay, and the direction of the interference, which sandwich assays causing false negative results and competitive assays causing false positive results. So we're still talking about this because even though manufacturers have been very engaged in reformulating assays and making them less prone to the biotin interference and increasing the thresholds, thyroglobulin antibodies are still among the assays that are most affected in the market by biotin interference. So here is an excerpt from the Beckman thyroglobulin assay, and it's saying that biotin concentrations as low as 10 nanograms per ml can lead to negative bias in thyroglobulin results as defined by a change by more than 10% in the concentration. To get to this threshold, you need 2 hours to clear a low dose over-the-counter biotin of 1 milligrams per day, but over-the-counter formulations are seeing up to 10 milligrams per day, which would take at least 2 to 3 days to clear biotin to not see interference. So again, this is one of the lowest threshold assays that we currently have in our clinical laboratory. Our previous assay had also an interference. The cutoff was 5, so we've improved, but we still need to move the needle on this interference. Thyroglobulin antibody also interferes, but the biotin also interferes. It's also a biotin-based assay, but the threshold is it's higher. So our recommendation is based on thyroglobulin. So the ultimate solution is for manufacturers to reformulate these assays and remove this interference. In the absence of that, patients must avoid taking biotin up to 3 days prior to sample collection. And if biotin interference is suspected, we can do retesting after withdrawing biotin. But if we have a sample available, we can also do a series of investigation or use a non-biotin-based method to troubleshoot a potential interference. Okay. So I want to summarize here the applications and the recommended use of high-sensitivity thyroglobulin assays, which, again, are widely available and available at our institution. So as was the case with conventional assays, these are not recommended for screening patients with thyroid nodules or preoperative baseline measurements. The main application is after thoracic thyroidectomy and radioablation therapy. And even though there's usefulness after less extensive treatment, it's going to be less useful because there would be detectable thyroglobulin concentrations. I want to highlight that one of the main advantages of these assays, the high-sensitivity thyroglobulin assays, is that it will obviate the need for using recombinant TSH stimulation in most patients, particularly those that have undetectable thyroglobulin levels in unstimulated patients. And the negative predictive value of these studies start at 95% and go up to 99%. So at the undetectable, unstimulated, high-sensitivity thyroglobulin would be sufficient to rule out disease recurrence in patients that are being monitored. The last application would be the possibility that these newer high-sensitivity assays allow for measurement of thyroglobulin and patient assessment even in the presence of thyroglobulin antibodies. So at this point, this evidence is preliminary, but very encouraging because high-sensitivity thyroglobulin is undetectable in patients that have no evidence of disease, whether they have antibodies or not. And when it's elevated, 90% of these patients with elevated high-sensitivity thyroglobulin have evidence of structural disease. suggesting that as the data accumulates, this could become an application of high sensitivity assays. So back to the case that I started with. The patient was then monitored with our new assays. Over time, there's 3 measurements after this measurement, and you can see that thyroglobulin antibody was consistent. There was no major changes, and thyroglobulin remained undetectable. So even in the presence of antibodies, which are not as detected by this assay, but detected more by another assay, this is consistent with no findings by ultrasound, and the patient is doing well. Thyroglobulin by mass spec was measured at this point, and it was less than 0.5, which again falls short of telling us if there's concentrations between 0.1 and 0.5, even though the most predictive information in terms of concentration for recurrence and evidence of structural disease are about 1 nanograms per mil. Okay, in summary, we've talked about the overall limitations of thyroglobulin and thyroglobulin antibody test. The results vary for both thyroglobulin and thyroglobulin antibody across assays and even across laboratories. Therefore, it's recommended that patients are baseline and monitored longitudinally using the same assay, preferably the same laboratory. And this is despite efforts to use reference materials to standardize both assays. So we're not there yet in terms of standardization. Thyroglobulin antibodies may interfere. Thyroglobulin mass spec will overcome this interference but does not meet the sensitivity performance needed for a high sensitivity classification. It's also more laborious and more expensive. So the standard of care continues to be assessing thyroglobulin with any high sensitivity thyroglobulin evaluation, and the evidence is accumulating about the possibility of the usefulness of these high sensitivity thyroglobulin assays, even in the presence of thyroglobulin antibodies. Heterophilic interference is rare, and these assays are still affected by biotin supplementation as opposed to many of our other assays, such as TSH, T3, etc., that have been reformulated. So with that, I'll take any questions.
Thank you for the presentation. Could you comment in terms of standardization? What are those standards? And what's the difference between IU and nanograms per ml or micrograms per liter?
Okay. I'll start with the first question. Maybe we can clarify the second question a little bit more. So these reference materials are usually made by a international standards organization, and they contain the molecule of interest, and they are manufactured by them and then sent to different vendors so that they calibrate their assays against these materials. So that is one way to aim at standardization. Other ways to aim at standardization is using a reference method, like an isotope diluted mass spec method, and aligning to that method. But in this case, these reference materials are created, sold, distributed, and the vendors try to align their assays to a certain response. There's different levels of removal from these materials because as we calibrate our assays, we're not getting this reference material from an international organization. We're getting calibrators that the vendor is doing or making. So we have a couple removal layers from this reference standard in current practice. So I don't know if that answered your question, but it's just an universal product that vendors are using to calibrate their assay and set values for their assays. The second question was about units. Can you repeat the question?
Yeah. The question was conversion, if possible, if somebody designates a certain amount as IU hypothetically, there should be some weight that's available to be consonant with it. The same issue applies to insulin.
Mm-hmm. Yeah. So, yeah, conversions are tricky in international units, and I don't have knowledge about how to do these conversions. I don't know if somebody else in the audience does, but typically they're assigned based on an activity value. One example that comes to mind is running. There's the possibility to convert running from activity to direct concentrations, although it's very flawed. And that is based on a certain value that was assigned to the renin formulation. So with that information, I suppose it could be converted, but other than that, I'm not aware of conversions. I don't know if anyone else knows more.
Hi, I have a question.
Yep.
Thanks, Jessica.
I thought you were going to help me answer that question. I was hoping.
Yeah, I'm just wondering what currently you're using. You usually use the antibody assays to detect how to measure the TG, whether by mass spec or the immunoassay.
Yep. So we're using the Beckman assays for both thyroglobulin and thyroglobulin antibody. And if the antibody is positive, we're reflexing those samples to ARUP laboratories, and they're measuring thyroglobulin by mass spec. Behind the scenes, we're collecting all the data for the immunometric assay for Beckman, aiming at being able to shed some light to this topic.
Can you mention something about cost of these assays?
Yes. Immunoassays are, most commonly immunoassays are cheaper, under $10, with a few exceptions of very new or expensive immunoassays. So that would be the cost to the laboratory. And mass spec assays are in the range of $100 by reference laboratories. The CPT code is the same and the reimbursement is the same, despite the large difference in cost. And also our positivity, so we're reflexing about 9.5% of our samples to mass spec. So just something to consider, given the possibility that the value is limited in patients with thyroglobulin antibody positive. Yeah.
So on the thyroid antibodies, they can interfere with other assays like TSH. So is there any value or any correlation between TSH and thyroglobulin that we usually measure together? If that correlation can give a hint.
Yeah. Sometimes we get a consultation about a potential interference, and we might see it across the board in more than one immunoassay, or we might just see it in one immunoassay. So there's really no correlation. It depends on the antibody that the patient has and the immunoassay that is being measured. Indeed, you might see the interference in one TSH assay measured with another vendor's assay and not see the interference. So there's really variability. Okay. One more question, I think.
Hi, would you please explain again when should we expect false negative with TG but mass spec when the anti-TG is positive? Because I had a patient that she had a positive biopsy with a positive metastatic lymph node, but the TG antibody was positive and TG with mass spec was negative. Thank you.
Yeah. So in that case, the information that we have is that thyroglobulin by mass spec was less than 0.5, so that we can be confident about that. Thyroglobulin antibody would not interfere by mass spec. The information that we don't have is whether or not there's some thyroglobulin present that we cannot measure quantitatively because the mass spec assay doesn't measure below 0.5.
Thank you.